The recovery time is very patient specific. And what we try to do is to decrease the amount of invasion into the tissue as much as we can. I think the robotic system is going to help us with that quite a bit. Right now, the average incision length is about 2.5 inches for a knee replacement. So that's going to be from about the top of the kneecap down to here. Well, if you're a very large person, your kneecap's going to be much bigger and this bump's going to be further, so it's going to be a bigger incision. So bigger people tend to have larger incisions, but that's generally about the length of the incision we're doing now, okay? That probably is not going to change. Well, why is that not going to change? Well, you have to get this stuff in there, okay? So you have to have enough room to get this in. So that's probably about the limit we're going to get to as far as incision length. Some of the things that we've been doing to help with the recovery after surgery, we have a new system which is called On-Q. And On-Q has a little ball which is filled with local anesthetic. It looks like a softball. It has a tiny little catheter that goes into the very front part of the person's hip. That provides numbing medicine that numbs up the nerve that supplies the front of the knee. We keep that in for 2 days, and for essentially the first 2 days, I had a lady this week that she said she was going to sue me for malpractice because she didn't hurt, so she didn't think I did her surgery. True story. True story. She went home yesterday. So she had no pain essentially for 2 days. Now most people still have some pain because this nerve does not get the back of the knee. So we've got the front numbed up, but we don't have the back numbed up. So it has really helped the patients for the first 2 days because they don't get as much pain medicine, they don't tend to get as sick, they don't tend to feel as bad. You know, they're ready to eat, they've got energy, they're able to talk with their family, they get up and they walk a little bit the first day. So this has been a really, really great development, and you'll hear more about that type of thing in the future. We're working on another application which will be for the hip replacement patients. Hip replacement patients don't tend to have quite as much pain as the knee replacement patients. So we've really kind of focused on how to make the knee replacement easier and better for those patients. Okay.
What about recoup time on that?
The recoup time, I've had patients who, you do the surgery on Monday, they go back to work on Thursday. And then I've had patients who 3 months down the road aren't ready to go back to work. I don't think they like their job very much. That's probably why. But most patients, I tell them at 3 weeks you're feeling pretty good, 6 weeks you're feeling very good, 3 months you're kind of starting to forget about it. Okay, that's kind of the average timeline. You can be getting around quite well at that 3 week period of time. Preparation, that's a great question. A lot of times, patients come in and they just want to get their surgery done. Well, a lot of times it takes 4 to 6 weeks, 8 weeks before we can get it done. Well, that's a great opportunity for them to work on rehabbing the muscles around their knee. The patients that have done that, so they've done one knee, they really didn't rehab beforehand. They've done their second knee and they did rehab before because now they know what to do, makes a world of difference in their recovery. Those patients that are more fit, are more active, have a lot quicker recovery time. So we've started a new program which is called the Total Joint Health Program. So when a patient comes in to see me and you need a knee replacement or you need a hip replacement, what we're going to do is have you see the physical therapist on your way out. So the day we say, okay, we're going to go ahead and do that, you're going to go see the physical therapist. The therapist is going to get you started on your preoperative program. Then you'll come to the hospital, you'll have your surgery, the therapist will work with you here. That therapist is going to do some measurements. They're going to communicate with your home therapist. So your home therapist is going to know where you are, how you're doing, what specifically you need to work on. You go home, you work with your therapist there. After 3 weeks, you come back to see me. If you want to see our therapist, they will look at you again and say, okay, here's what we need to work on. If, let's say you live an hour and a half away, well, you can visit with your therapist there, but you will be directed by our therapist. So they'll say, this is what this patient needs to work on. So then in 3 months, you come back to see me, or 6 months or a year. When you come back to see me, our therapists are going to see you at no charge just to make sure you're doing okay. If you have some deficits, you need some things you need to work on, they're going to direct you in that arena. Maybe you'll see your therapist at home, maybe you'll see our therapist, but we want to make sure is that patients don't fall through the cracks, where they kind of get to a certain level and yeah, they're pretty good, but they're really not at their greatest potential. So this program is designed to really make sure that our patients reach their maximum potential. The therapist will continue to work with those patients for up to 2 years, meaning it's your 2-year recheck when the patient comes to see me. the therapist will visit with them and say, okay, how are you doing? Are there things that you still want to get back to doing that you're not being able to do? Well, let's work on this so we can get you there, okay? So this is a very novel, it's a new program. We're kind of just getting it going and rolling, but I think it's going to be very good for our patients, particularly those that really want to get back to fairly higher demand type of activities. Swelling is kind of a normal part of the process, and it's one of those things that is extremely variable. People that have swelling before surgery tend to be people that are going to get more swelling after surgery. Okay? As part of the process, the patients have to be very good about watching their activity level, watching their swelling, making sure they're elevating, making sure that they're using ice. We use the compression stockings usually for about 3 weeks if your patient's having swelling. But because with any of the surgeries you're going to have some bleeding and some fluid collection, it's going to tend to make them swell. Some people will have some swelling for several months, particularly when they're very active, but that swelling tends to kind of come and go. Most people do not have persistent swelling. And it can take them maybe a year for it all to be gone and the tissue to really all be matured, but it usually does go away.
Can you get out on your knees and look under the bed after you have this done?
Well, yeah. We used to do the incision directly in the front of the knee, right here. And I would say 20% of those patients could kneel on their knee. Now, the incision is more towards the inner side of the knee over here. And now I would say it's more like 20% can't kneel on their knee. Okay, so that has gotten better. I let patients do it. I don't think there's any harm in doing it. It's just that they're comfortable doing it. When you have a knee replacement, or even any knee surgery where you cut the skin in front of the knee, you're going to end up with some numbness out here. And that's because the skin nerves go in this direction. So when you cut the skin, of course, you're going to cut the small skin nerves. And it takes about a year for that feeling to come back over here. And sometimes it never completely comes back. And that can just be kind of bothersome for people when they're trying to kneel. Some people use knee pads, but I would say 80% of people can kneel on them. So most patients go home with home physical therapy. So the therapist will come out and work with them at home. And then at 3 weeks, I see the patients back. I wait till all the pain and soreness is gone, and then I have them come back to see me. And then we decide if they're going to do outpatient therapy. Sometimes we'll extend the home therapy. Some patients don't need to do any more therapy, but most people probably on average do about a total of 6 weeks, I would say. Okay.
How long does one last?
Well, if you look at the 20-year results and look at how many had to be redone in 20 years, you'd have probably about 85% have not had to be redone. So that's pretty good. For something mechanical to last in the body that long is terrific. If you walk just your normal activity for a year, you're probably putting that joint through maybe 4 or 5 million cycles. So that's moving a lot. So you have to have a very durable material, and that's why we've worked on getting different materials that wear less in the joint replacement. And we use some of those same materials in the hip. In the hip, it's different because we can use a metal material that rubs on a metal material. We can also use a ceramic material that rubs on a ceramic material. So this is an example of a metal on metal. So this is the thigh bone here, okay? And so this is a metal cap. This is called a hip resurfacing. This is a metal cap that goes over the femur bone. And this is a metal surface that's put into the socket. So then when the patient walks, it's moving like this, okay? So the metal is very durable. The metal does not really wear. However, if you measure metal levels in these patients' bloodstream, they will have some metal in their bloodstream. And that worries some people. The other kind of negative of this is that you can develop an allergic reaction to metal, okay? So you have to kind of be careful on which patients you're using this particular material in. We also have this oxinium material, which is the black material that you can use for this ball, okay? And why would we use that? Well, that material is very hard, it's very smooth, and it doesn't cause much wear. If you look at why do joint replacements fail, okay, why in 15 years are they going to not be working? Well, it's going to be because the plastic is worn out. So we want to avoid that. So that's why we're using some of these different materials in joint replacement. This is an example of one of the hip resurfacing implants. And it's actually fairly heavy. Patients always say, after my joint replacement, I I gained a few pounds. Was that because of what you put in there? And for this, it probably is, because this is probably about a pound or so. But the most implants are probably less than a pound. But I'll pass this around and you can see what it's like. You can see how this has very little friction in it. See how that can spin like that? And just keeps on going. So it's pretty amazing. It's an amazing amount of machining technology to make a system like this that functions so well in the human body.
Is everybody's the same size?
No, they're not. Knee replacements come in about 9 different sizes, but there's various combinations. You can use one size for the upper bone, a different size for the lower bone. They don't have to be specifically size matched. Same with the hip replacement. The socket comes in different sizes, and the stem portion in the thigh part comes in different sizes. So that's where you get the question about, well, is it a women's knee or is it a man's knee? Well, the smaller sizes tend to be more those that women are going to get, because they have smaller bones, they have smaller joints. So those are the implants that tend to be made more towards women's geometry. As you get bigger, then you start to look more at men's geometry. And there are some subtle differences, but that's how most of the companies do it. That's how they kind of make the changes to accommodate women's sizes and men's sizes. So women that are up in the bigger sizes, they probably need to have more of the men's geometry, okay? I tell patients, when we're doing your hip surgery, my #1 priority is to make sure that the tension in your hip is correct, meaning I don't want that hip to slip out of the socket. So how do we do that? Well, it's the muscles in the hip that really hold it in position. So sometimes if we lengthen the leg a little bit, it will tighten up the tissue and that will make that hip more stable. So I usually tell patients, my #1 priority is I want your hip to be stable, and that may mean I'm going to lengthen you a little bit. My legs are about this much different, and 95% of my patients are closer than mine are, okay? So a little bit of difference patients accommodate to very, very well, okay? So usually you can get them within about a 1/4 of an inch, okay?
It doesn't bother the other hip to have?
No, there is some adjustment. It's the spine that has to adjust, because if one leg is different than the other, how do we accommodate? Well, we tilt our pelvis to accommodate that. So sometimes it'll actually bother their back. Most people's leg, when we do the surgery, is shortened. Why is it shortened? Well, if this is the socket and this is the ball, they wear out the cartilage, so that shortens their leg. So I tell patients, when you first get up, your leg's going to feel like I made it too long, and you're not going to like me for a couple of days. And that's just because over the years, that hip is gradually worn out, and then within an hour, boom, we've lengthened it back out again, okay? And most of them, it takes them about 3 weeks to really feel like, yeah, that feels like it's the way it should be. Even if I leave it a little shorter, they still feel like it's long. And it's just because it's a dramatic change in a short period of time. I had one lady, she said, yep, you made my leg too long. And I said, no. I said, no, she wanted to put a lift in her shoe. I said, don't put a lift in your shoe. It's going to be fine. So she said, okay. So she came back, and this was like 3 months later. She said, I had to put a lift in my shoe. I said, well, let me see the lift. So she pulls it out, and she'd taken a Kleenex and folded it over 3 times, and that was the lift she put in her shoe. So I think it might have been a little psychological. So, here, I'll pass this around. You guys can look at that too. And for the resurfacing, you don't have the stem that goes down in the bone. For the total hip, you do have the stem that goes down the bone. When do we use this one? This one tends to be for our very active patients that have very good bone quality, okay? You can't do this in a lot of older patients because the bone is too soft and they can break this off in their hip, okay? So older patients, we tend to stay away from this. I use this for my patients that are very, very active, patients that want to be very high demand. For example, if they want to play soccer, if they want to hike extensively. I have one gentleman, he's probably the oldest I've done, he's 72. He hikes 7 miles in mountainous terrain several days a week. So for that person, this is a better implant. Well, why won't we use this for everybody? Well, it actually takes a little bigger exposure to get this in. So it's really a bigger surgery. Even though we're not putting in a lot of stuff, it takes a bigger surgery. With a total hip, we actually remove the entire ball. So with the total hip, we're going to remove this completely and take this off, and then we're going to put the stem down in the bone. Well, if I go in and I take this bone out, that gives me some room to work. Okay, so I can do a total hip through a little incision like this. if I'm going to do this resurfacing procedure, I'm not taking anything out. So I need to get in there to be able to put this on, to be able to put this socket in. So I need a bigger exposure to do that. So kind of everything kind of has its pluses and minuses. And if you're at the point where you need something like this, it's good for you to research it a little bit and ask the questions, you know, what implant is best for me, for my lifestyle? You know, you don't want to get the same implant that you would use for every single person. You know, you want to know what's going to be the best one for you. And there are pluses and minuses of all of them, and you and the surgeon need to decide which one is the best fit for you.